have the pulmonary edema, right? If you get really bored, you want to look into it more. It's called capillary dynamics of blood flow and everything. You will eventually get into this. Maybe not necessarily in here, but you will. And so we have an accumulation in the fluid in here, which is going to produce a sound, that airway sound that we're going to talk about in a second. Really, really bad pulmonary edema will produce this sort of frothy, pink, frothy sputum. And hopefully you'll have a chance during clinical to see that. And then right-sided failure is going to produce. You can have right-side failure and not have left-side failure, okay? Or you can have right and left-side failure, okay? So you can have the pulmonary edema with the peripheral edema. A short video on describing how to measure the pitting edema.
So this presentation is going to be on the levels of pitting edema and how to grade pitting edema. But before again, we have to talk about the fact that not all edema is pitting edema. There are many different causes of edema, two of which are hydrostatic pressure and decreased oncotic pressure, which is the proteins in the blood. Both of those result in pitting edema typically, and one of the causes of non-pitting edema is lymphatic obstruction. So the pitting edema grading scale is typically based off 1 to 4 levels. There are many different variations of specific rules that different ones can follow, but typically they are something as the following. So the 0+ is obviously no pitting edema. Sometimes it can be referred to as 0+. The next level up is 1+ pitting edema, and this is slight pitting edema, and it's hard to see. It's hard to see this level of edema without actually putting your hands on the patient. So, good tip is to check for this type of edema when you're checking for pedal pulses and stuff like that. And so the 1+ pitting edema is approximately 2 millimeters. When you push down, it's a 2 millimeter indentation approximately, and it disappears almost immediately when you remove your finger. So there's no remaining marks. So the next step up is 2+ pitting edema. This is mild pitting edema, and the indentation is approximately 4 millimeters when you push your finger down. And different guidelines have different times, but typically it's about 10 to 25 seconds. So this short amount of time, and usually goes back to normal, and you can't tell that you've pushed down on the skin. So the 3+ pitting edema is moderate pitting edema. This is when the indentation is between 4 and 6 millimeters in depth, and this lasts for a significant amount of time, oftentimes more than 1 minute. And typically by this point, the edema is obvious to the naked eye, and you'll be able to see that somebody is edematous. So the 4+ pitting edema is severe pitting edema. It's 6 millimeters indentation or more, and it lasts a severe amount of time. Once again, it's obvious. When somebody has 4+ pitting edema, it's obvious that they're edematous in whatever extremity that the edema is present. And the texture of pitting edema, 4+ pitting edema, is almost as if it was Play-Doh, where you can mold and shape their extremities because the pitting edema lasts for so long. And once again, the 4+ pitting edema is the highest and final stage of the pitting edema scale.
Right, so +1, 2, 3, and 4, okay, and it's about how deep that it goes, right, in millimeters, and then how long it lasts. I've pushed in on people's cankles before, and 20 minutes later, they still have a pit there, okay? So you'll see that all the time, just as he mentioned, not all edema is CHF. You have lymphatic blockages. You have different hydrostatic pressures. Different things will cause it. A twisted ankle is going to cause what? Swelling, edema, right? You have fluid in there that spaces out, so it's going to cause edema. So different cases for this pitting edema. Okay, so it's a little hard to see on the picture, obviously, but we would rank this 1+, 2+, 3+, 4+, right? When we talk about the edema, not necessarily something we have to hang on to forever. I just want you to be familiar with it because you will see these CHF patients, and this is what they're doing when they're judging that CHF. You've seen the patients with have on socks, and you take their socks off, and then yeah, you see the imprint on there. Okay, so they have a little edema there, a little swelling. All right. With this, you're going to have different airway sounds. Okay. Do I have them listed? No. So you're going to have, we won't listen to it on here now because we have Steve that I can produce these airway sounds in, so they sound a little bit better. Okay. One, you have rails. If you're from the north, rawls for some reason. Okay, or rails, or in Texas, we call them crackles. I hope that's spelled right. Crackles. Rails or crackles. What rails or crackles are is that it's fluid and air moving through fluid. Keep that in mind, okay? Air moving through fluid. So rails or crackles is fluid in the smaller airways, okay? In the small airways, and then you have rhonchi. Rhonchi, that's misspelled. Huh? Yeah. Rhonchi is fluid in the large airways. So rails, crackles, fluid in the small airways. Rhonchi, fluid in the upper or larger airways. The way that you can listen to this, and I was going to bring it, I just didn't do it for some reason. I thought of it, but I didn't bring it. Is a carbonated beverage, right? Canned Coke or something, you pop it and it bubbles out. Right? You have the fizz coming out. Take your stethoscope and put your stethoscope over the top of that, and you'll hear the bubbling sound, right? You'll hear this bubbling sound, okay? Because that is gas moving through fluid, right? It's CO2 moving through Coca-Cola, right? So you have fluid moving, you have gas moving through the airway, okay? Rhonchi sounds, and I know that everybody has done this, especially as a child. You have that soda, with the straw in there, and you blow air into the straw and it bubbles up. Everybody's done that before. That's what called is rhonchi. It sounds like that. It's in that larger airway. Okay. Think about that straw. It's in the airway. It's a big tube. Okay. Especially if you get one of those great big Whataburger orange straws. You know, they're like huge. Okay. And so it's a large airway, and you're blowing air through fluid. So it sounds like rhonchi. So rails and rhonchi. Okay. The other things that you'll be able in pulmonary edema, right? Rails and rhonchi. Okay. So the other things that you'll be able to hear are heart tones. You have two different heart tones. You have S1 and S2, and those are what? S1 and S2 are.
It's I know what he's talking about.
Let me tell you, because it's Friday. Love dub, right? Love dub, love dub, love dub, love dub. You have ba-boom, ba-boom, ba-boom. It's S1 and S2. Those are normal heart tones. S1. Everybody should have S1s and S2s, okay? There's different places that you listen for these heart tones, but we're not going to go into that, okay? Because we don't really need to. But you have love dub, right? You have a S3 sound, which is an extra sound, correct? And so it's going to have extra. I have Kentucky out to the side of it because when you're listening to it, you know how when you're listening to a sound or something, like a guitar, they're playing a guitar and you can hear the words. Does that make sense? Because I'm like zero music abilities here, okay? But an S3 sound sounds like Kentucky. So you're listening to the heart tone, and you can listen, just for a quick reference, right here. Okay, so to off, because that's where the ventricle is. Alright? So you can listen, and when you're listening, if you have an S3 tone, you hear this. It's go love dub and love dub, love dub, love dub, Kentucky. It sounds like Kentucky, okay? It does. It really does, okay? If someone has S3 tones, okay, they are typically in right-sided failure, okay? So if they have pulmonary edema, okay, this should sound something that, hey, I want to try that, right? So you get this patient in the hospital, they have pulmonary edema. I mean, not pulmonary edema, peripheral edema, right? Break that stethoscope out and listen to those heart tones to see if they have S3 tones. We did that one time in the ER, and it liked to have floored the nurse when we did it. She was in there, she was doing her assessment, and the students went around, and I said, well, go ahead and listen. I did first, and I'm like, okay, listen, right here. And she was just doing paperwork, and the students listened, like, yeah, that's a Kentucky. It sounds like Kentucky. They have S3 tones. And she did this. And she was shocked that they knew what S3 heart tones were. And she goes, oh, he's in failure. I mean, you had the pulmonary edema. He goes, oh, he's in failure. So she listened and goes, yep, he has heart tones. And because they had the edema, but we really hadn't talked about CHF very much. There's a language barrier. One of the students were doing the interpretation, but so we hadn't got really around to if they had CHF or not, or how to explain that. And but now we knew it because they listened to heart tones and go, okay, they have S3 tones. They're in failure. Okay, this tone will actually probably show up before the edema shows up. So when you're doing your really detailed assessment, you listen for heart tones, and you have an S3 tone, they're probably going into failure. All right. Something to use that $20 stethoscope for. And then you have an S4 tone, which sounds like Tennessee. And you're listening to that, instead of that love dub, you have Tennessee, right? And you hear the extra tone.
Also,
so you
Tennessee, like the love dub, all three they sound kind of like the same, right? While Kentucky love dub is normal, and then you hear that little extra.
Yes.
Okay, so that's what it. Okay.
Yeah. Once you hear it, and if I can figure out how to do it again, I can produce these heart tones in Steve, so we're listening to it, okay? But once you hear it, it's like a smell. Once you smell it, you'll never forget it. Like a lower GI bleed. Once you smell a lower GI bleed, you will never forget that smell. I guarantee you that, okay? That's like number 3 on the bad smell list. My bad smell list, okay? Huh?
Your lower GI story, or you want to list?
Yeah.
Yeah.
So, S3, S4, okay, heart tone. So that's something that you look for. So let's go back to these signs and symptoms. Remember the signs and symptoms. Alright? So when we do our assessments, we're basing our treatment and everything on these signs and symptoms, correct? Confusion, anxiety, increased work of breathing, increased respiratory rate with heart rate, JVD, maybe have some ascites, some edema, lower edema, pulmonary edema, tripoding, diaphoresis. So there's a lot of different signs and symptoms. And then we go to our treatment is make sure that you position them, okay? Oxygenate, do a very good assessment. We'll talk about CPAP when we get into respiratory, but you can do CPAP, provide oxygen. You might have to suction. Later in our assessments, you'll want to give a diuretic, okay? So over here, because we're sort of doing the mirror of what we're seeing in the hospital, so you'll give a diuretic. They're going to have chest pain, so you would give, because of all that fluid, so you do a 12 lead. Protect their airway, oxygenate them, diurese them, okay? Labs. There's a lab, and I don't know it off the top of my head. There's a lab that you can draw to, it's a quick lab, like a troponin, that you can draw and test to see if they're in failure. It's a marker that will show you as well as they're in failure. I'll get the name for you later. Everybody good with CHF?
Yes, sir.
Any big questions there? No? Okay. Give me 10 minutes and I'll get through this next part. And the aneurysm. An aneurysm, this is a nice nasty little picture of one, pretty cool picture actually. You have this sort of bubble. You have the vessel. Let's say this is an aortic, the aorta, okay? And because you can get an aneurysm in any artery, okay? Cerebral aneurysms back here at the Circle of Willis. People get them all the time, and they don't even know it until they start leaking. Because they don't produce signs and symptoms until they start leaking, okay? But we're going to talk about aortic aneurysms right now. And so you have the aorta, you have this normal looking aorta here, but over here you see the little bubble. Has everybody seen like a bubble on the side of a tire or heard about that? That the sidewall of the tire gets this little bubble on it? Okay, it's about to blow up. You have a little bubble on the side of your tire, you need to replace that tire really quick. Because it's like a little aneurysm. It's going to blow up. It's going to rupture. So you get a small bubble on the side, and and depending on where that aneurysm is, okay, it could be fatal. If it's what's called an abdominal aortic aneurysm, ascending down, right? Abdominal aortic aneurysm, and then it's a large aneurysm. If it ruptures, it could be fatal. Think about that. I put my thumb in the aorta the other day, right, at the lab. How big it is, and how fast blood will come out of it. So you could have a rupture like this. In the aorta, that would probably be fatal. Okay. It is definitely surgical to go in and repair this. What happens what happens is in an aorta is the middle layer, which is what? Middle layer of the vessel, tunica media, very good, weakens, okay, and then blood comes out in between the middle layer and the outer layer, which is tunica, right, and then you develop a little bubble there. Right. Some people have chronic aneurysms, They might be big. They're measured in millimeters. There's a laundry list for why they don't get them repaired. Okay, that might be too old and fragile to go into surgery. It may be too big to repair. The surgeon looks at it and says, we can't repair that. Just be really careful. Okay? This is why we don't palpate abdomens unless we look at them. They can have an aneurysm there. Okay? One of the it'd be a sign because you can see it. One of the signs of an abdominal aortic aneurysm is when you palpate in on the abdomen, it pulsates. Okay, it looks really cool. Okay, but don't get all your friends over there and keep, look at this, man, and keep pushing in on it because it could go, right? And then death. Right. So, causes, family history, arteriosclerosis, 95%. Okay, or due to this fatty buildup in the aorta, the middle layer just becomes weak over time. High blood pressure is a big reason for the aortic aneurysm because the systolic pressure is what? What's the definition for systolic pressure? They're in systole, right? Very good. So you have systolic pressure. So a normal pressure my normal pressure is like 118, okay, systolic pressure. So that's not a lot of pressure, right? And now you have a pressure of consistent pressure. Let's say you have someone that has hypertension, okay? You have a consistent pressure of 160, let's say. Okay? A consistent pressure. Now, they need to be on blood pressure medicine to lower that, right? Let's say they have that consistent high blood pressure, systolic pressure. And we are concerned about the diastolic because it's at rest, right? But now let's say we have 220. Yeah, you don't have to really do a lot of math. Say, good, not so good, bad, bad. Okay, so because we have all that nice coat of bluebell on the inside of that artery, all right, in this pressure, think about it logically. You add more pressure to that in the inside and you have that plaque build up, okay? What's going to happen to that plaque? Just logically, what's going to happen to it?
It's going to build up, and eventually it'll just break.
It's going to break. The more pressure you put on it, it's going to break, right? You have the balloon. Well, that's a bad thing because it doesn't take much pressure, okay? But you have a sac and you're putting pressure on it, and that sac is full, okay, and you keep putting pressure on it, eventually it's going to break and the contents is going to come out, right? So that blood pressure, and of course trauma can be a cause of an aortic aneurysm. So signs and symptoms, this is what we look for. Discomfort in the belly, pain in the chest, especially in the lower back, okay? Sort of a deep pain. They're saying, oh man, it just feels bad. One other thing that we look at is the cold foot, or the reason that on our flow chart that we palpate both extremities to check for equal temperature, right? Because if we have warm leg here, cold leg here, cold equals what?
Oh, there's no circulation.
Circulation, very good. There's no circulation. Okay, so that as well. Another one, the pulsating mass in the abdomen. Okay, one that you can check very quickly. And this is why we check pulses times 4. Check both radial pulses, because if I have a weak pulse on one side and a strong pulse on the other side, and we haven't defined that yet, but a weak and a strong pulse, okay, suspected aneurysm. Okay, So right there, just by checking a pulse, you can look at that. This patient is going to complain of a pain and a tearing type pain. That I've heard him say it feels like someone's ripping me apart. Okay, so that's something that you can suspect as well. But the first aortic aneurysm that I was involved in as a paramedic student was the only symptom was lower back pain. This guy had come in and he had lower back, or he called 911, he had lower back pain. We got there going, great, low back pain, get in your car, right, go to the hospital. And he got up, put him on a stretcher, we were doing our assessment, and as a paramedic student, I was doing my head-to-toe exam, and I pulled up, looked at his abdomen, I pushed on his abdomen. My preceptor was looking over me, as always, okay? And he was looking over me. When I pushed on that abdomen, it pulsated, and like that, the whole atmosphere of the call changed. I saw it, the preceptor saw it, I knew what it was, he knew what it was, and we changed courses 180 degrees. I mean, it was a big time emergency, okay? He didn't know he had an aneurysm. So I'm cautious. 24 years later, I'm still cautious of someone with low unexplained low back pain. I look at that abdomen, okay? Very important. Lessons learned. And then the last one is this that we'll talk about today is this aortic dissection. It hasn't ruptured, it's tearing right now, it's dissecting, okay? And so you can see the outer layer here in it, the tear in the lining, there's the blue, right? Tearing this lining, and blood will now flow through here, okay? And you can, if you use your imagination, you can see when enough blood flows through there, that this is going to form a bubble right here, okay? Essentially the same signs and symptoms as an aneurysm, the dissect, the tearing. But you really get that patient telling you, oh, it feels like someone ripping me in half on this one, okay? So an aortic dissection. This is not as critical, depending on the size of it, I guess, as the aneurysm. But an aortic dissection. So like we said, radiates, got some decreased loss of consciousness or syncope, you got some decreased blood flow going there, right? Decreased output. Because where's the blood going? It's going in here, not to the cells, right? This throbbing, aching pain.
So they'd be pale as well.
Yeah, weak pulses, good. They could be pale. Okay. So aortic aneurysm or an aortic dissection. Diaphoresis, weak pulse. Why does it seem like I'm going backwards? Hypertension, aortic stenosis, valve problems. Stenosis is hardening. So you hear aortic stenosis, it's hardening. Cocaine use. Cocaine messes up those vessels. It messes up the sympathetic nervous system. Arterial sclerosis, hardening, narrowing of the artery itself. And then on to respiratory. If you understood that, you would laugh hysterically, okay, when I saw this. But any questions on CHF, aortic aneurysm?
How long can it take for like a bubble to form? Like will it form over like months or come
Yes.
weeks?
Yeah, it could be very chronic. Yeah, that's a good question. The aneurysm could be very chronic. It could form over years. Okay, so yeah, it could be chronic.